Hello students, today we will discuss about positive and expiratory pressure, that means PEEP. It is most common asked question in MD anesthesiology examination. PEEP is the fundamental component of mechanical ventilation. It is used to maintain alveolar patency at the end of expiration. It improves oxygenation. It reduces risk of atelectrauma. PEEP is essential in management of ARDS, that is acute respiratory distress syndrome. It is useful in cardiogenic pulmonary edema and also perioperative or postoperative atelectasis. By maintaining positive pressure in the lungs, PEEP enhances number one FRC, number two intra. It decreases intrapulmonary shunting. It improves the ventilation perfusion matching. Inappropriate PEEP leads to complications like barotrauma, valvulotrauma, compromised hemodynamics due to increased intrathoracic pressure. Optimal PEEP vary depending upon the patient's clinical conditions and it requires careful titration. The advanced imaging, ABG, lung mechanics, and hemodynamic monitoring is a guide for individualized therapy of the PEEP. PEEP is used in invasive and non-invasive strategies. It is used in emergency cases, in critical care, perioperative settings. The PEEP is a positive pressure that remains in the airways at end of the respiratory cycle. It is that pressure is greater than atmospheric pressure in patients on mechanical ventilation. Now, PEEP is classified as extrinsic PEEP and intrinsic PEEP. Extrinsic PEEP, that means the PEEP is that is applied PEEP. It is delivered by ventilator to prevent the alveolar collapse. What is intrinsic PEEP? Intrinsic PEEP, it is also called as ATO-PEEP. It occurs when there is an incomplete exhalation and that incomplete exhalation leads to air trapping. Develops in obstructive lung disease. The ATO-PEEP also develops during high respiratory rate. With excessive tidal volume, it complicates mechanical ventilation by increasing work of breathing and impairing the hemodynamics. Recent literature suggests that PEEP selection should be individualized based on lung mechanics, oxygenation targets, and patient specific factors rather than applied as a fixed value. Now we will see the function. The extrinsic PEEP is ventilator setting that can increase the oxygenation. That means extrinsic PEEP is a ventilator setting that increases the oxygenation. According to Henry's law, solubility of the gas in liquid is directly proportional to pressure of gas above the solution surface. Thus, increase in PEEP will increase pressure in ventilatory system. The external pressure increases, oxygen solubility increases. It allows it to cross alveolar capillary membrane more easily and increasing blood oxygen content. The PEEP is applied to prevent end expiratory collapse during passive exhalation. The applying PEEP inside the airways can open the airways that may otherwise collapse. Decrease in atelectasis will improve alveolar ventilation and decreases ventilation perfusion mismatch. Extrinsic PEEP also decreases work of breathing. By decreasing breathing work, the carbon CO2 and lactate production also decreases. It reduces need for high minute ventilation. Now the issues are concerns with PEEP. Extrinsic PEEP causes physiological and clinical complications. Extrinsic PEEP increases intrathoracic pressure. As a result of it, the right atrial pressure increases. Therefore, venous return decreases. Therefore, there is decrease in preload. As there is decrease in preload, there is decrease in cardiac output and there is decrease in mean arterial pressure. If patient is in distributive shock, for example, septic shock, neurogenic shock, anaphylactic shock, already there is decrease in systemic vascular resistance. So therefore, there is worsening in decrease in mean arterial pressure. The increased right atrial pressure and venous return may benefit in patients with cardiogenic pulmonary edema and in patients with volume overload. PEEP does not directly affect the cerebral perfusion pressure. Cerebral autoregulation will compensate for changes in mean arterial pressure. Next, extrinsic PEEP can induce harmful barotrauma in stiff lungs by increasing plateau pressure. Now we will see the clinical significance. Begin with We should begin with lowest effective PEEP and increase as tolerated based on patient comfort, oxygenation of the patient, and hemodynamic status. PEEP should be individualized rather than fixed. Monitor plateau pressure to prevent barotrauma. Maintain plateau pressure below 30 centimeters of water. Monitor mean arterial pressure while increasing or decreasing PEEP to avoid hemodynamic compromise. What are other issues? Auto PEEP. Auto PEEP, it is also called as intrinsic PEEP. When mechanically ventilated lung not completely deflate, air gets trapped inside at the end of exhalation. This trapped air generate positive pressure and it is called as intrinsic or auto PEEP. It increase in intrathoracic pressure causes hypotension, high plateau pressure and barotrauma. The factors leading to atopressure, leading to atopeep. These factors are airway inflammation, if there is mucus plug that generate dynamic airflow obstruction. Another, if there is high lung compliance, example is COPD, high tidal volume ventilation, it results in air trapping, high respiratory rate, it results in shortened expiratory time. What are the clinical clues that suggest auto PEEP? Incomplete return to baseline on volume time curve during mechanical ventilation. That means volume curve that does not return to zero before next breath delivered will suggest auto PEEP. Next, elevated plateau pressure. Third, use of accessory muscles during exhalation. If there is decrease in blood pressure, if there is prolonged expiratory phase, and there are signs of respiratory distress. Now we will discuss what is the treatment for auto PEEP. Number one, decreased respiratory rate. Second, allow longer respiratory time and lower inspiratory to expiratory ratio between 1 is to 3 and 1 is to 5. Next, decrease the tidal volume. Next, decrease the respiratory demands by decreasing carbon dioxide and lactate production. Examples, that means you should control the fever, control the pain, ensure adequate sedation, control anxiety, treat the sepsis. Minimize the minimize the airflow obstruction by treating bronchoconstriction with bronchodilators and suctioning mucus plug. Treat airway inflammation with steroids when indicated. Thank you.